Hey guys, welcome back to the FOAMfrat podcast. Tyler and Sam with you on an episode discussing pulmonary embolisms, but a very specific population. This is the crashing acute pulmonary embolism, where you're trying to figure out what can I do to get this blood pressure up before they can go in and do embolectomy or thrombectomy or whatever to remove that. And so Sam and I did a podcast on the clinical signs and symptoms of a pulmonary embolism way back. I don't know, last year sometime was when we first started doing the video format.
Last
And
summer,
we had a
maybe?
lot of people reach out with some questions regarding that and really regarding like the pathology of it. And so we're going to discuss that just a little bit here. And then we're going to go over to the actual episode where I sit down with Shane O'Donnell, Brian King from the FOAMfrat team, and we discuss all the logistics from like blood pressure management, ventilator management, and fibrinolytics. So Sam, as you watched the episode with Shane and Brian, what were some of the things you were thinking?
I was thinking about when you guys are talking about pressors, like logistics of pressors and stuff, and like levofed versus epi. And at one point, Shane brought up vasopressin as well. And I was like, I seemed like vasopressin is really good, but I don't think you guys got around to like why he brought up vasopressin. I was like, ooh, I want to bring that up in the intro. Talk about epi and talk about vasopressin. Both of those can provide you with pulmonary vasodilation, which is really cool. And you guys talked a little bit about like, should you give like nebulized nitro or whatever? And when you think about like what a pulmonary embolism is, the main problem is that you have this blood that doesn't want to flow through the lungs for any reason, because obviously there's like a big clot there. So anything you can do to like get more blood to flow through those lungs is good. And so when you guys are talking about like the inotropy, like the increased strength of that contraction with the epinephrine is really good, because it obviously helps out that right ventricle. But also the beta 2 in that epinephrine will give like some vasodilation, and then vasopressin will do that as well. And so that's kind of cool, because like the cumulative effect of that is that you get some peripheral vasoconstriction, and so you're not worried about like perfusing your skin quite as much and like just like unimportant areas and whatnot. But it is like shunting that blood to the core, and not only is it shunted to the core, but it's a little bit more likely to go through the lungs as well, and that helps like decompress that right ventricle a little bit. So I thought that was cool, the conversation about the epinephrine and the vasopressin.
Yeah, the vasopressin just kind of being on in the background. It's not something you really titrate. You just got it
Mhm.
running just a basal, 0.04 units or whatever, just in the background. And then adding on that epi or starting with epi. I don't know if that happens that often. It seems like most of the time you start off with levofed and then you're like, holy crap, this is really bad. And then you add on epi, and then maybe you start coming back on your levo a little bit once you get your epi to a spot to where you're
Mhm.
maintaining a sustainable map. But it
Yeah.
was interesting to look at the idea of pulmonary vasodilators with
Mhm.
that physician that I referred to, that Orrin Friedman, who
Mhm.
was talking about the inflammatory cascade that you get when you have a pulmonary embolism. And you think about inflammatory mediators as like vasodilation and increased
Mhm.
capillary permeability, but they actually create like this situation where your capillary permeability is allowing fluid into the interstitium, and then you're actually pushing down on the
Yeah.
vasculature. So I thought that was an interesting dynamic that I personally don't know of anybody that's doing inhaled nitro. I thought maybe Joey Lerner said he was. Do you remember that?
There was like yeah, and I just got an article emailed to me the other day about inhaled nitro as well. It's like 5 milligrams. It's super dependent on concentration. And I remember it was like a breakdown of, I can't remember who sent that to me, but it seems really logistically simple, and it seems like pretty, like the safety profile is pretty well established. But yeah, like you guys always were talking about, like don't just go out and like, hey, I have IV nitro and I have a small volume nebulizer. Like let's throw this in here. But if that's something that your service approves of or whatever, it might be something to think about if like ipaprestinol or I know, probably always EPO, like that would be the only thing
Yeah.
available. If Flolan, ibuprostenol isn't available, and obviously like probably not going to start somebody on I know before they leave the emergency department, it could be a simple thing to get started that lasts 20 to 30 minutes, nebulize it over a little bit, and then that could reduce that afterload. And so yeah, there's like the pulmonary vasodilation aspect of it. I think like the vasopressin, the epi can help with that. Nitro, if that's like something you can do or not, something to think about. But also like the increased inotropy that you get from the epinephrine as well. Like people forget, like, and I always, this is never included with pulmonary embolisms. It's like it's an obstructive form of shock. I remember the first time I read that, like that's how it was classified. Because I always think like tension pneumothorax or pericardial tamponade. And like those are so easy to picture because you picture this big collection of fluid around the heart. You picture all this air in the thorax. Like, oh, that's easy, like an obstruction of blood flow. But then you think about pulmonary embolism, which can be huge or massive by definition, like you guys are talking about. Like that is a huge obstruction to blood flow. And so if you just think about that blood flow, okay, it can't go out to the lungs. Where is it going to back up? Right heart. What's going to happen if the right heart gets really big? Well, it probably won't be able to perfuse itself very well, and it'll probably start knocking into like the left ventricular area. So it's like if I can vasodilate into the lungs, if I can make the right heart pump harder, that'll get rid of some of that blood, allow the left heart to fill. And as long as I don't screw up the ventilation too much and overpressurize these lungs, because you don't have very much air, you don't have very much blood fighting that air in the same space, you can create that VQ mismatch. So it's like as long as I keep my pressures low, vasodilate into the lungs, make sure the right heart can still pump, provide adequate, it's kind of counterintuitive too. Like you guys are talking about a little bit like ventilator settings. This is where learning about like the difference between the VQ mismatches really helps, because if you're thinking this patient's not saturating well and you're like, I'm going to increase my mean airway pressure and I'm going to start with the PEEP and then the I time,
Yeah.
and the tidal volume and all that kind of stuff, that's really going to inhibit that blood flow through the lungs. So this is a totally different side of things. Usually when you think about oxygenation issues, a lot of times we think about an issue going on in the lungs, but kind of prepping your brain for the conversation that you guys had, this is a problem on the blood side. And so this isn't something that like albuterol fixes or anything like that. Like it's a completely different process.
Yeah, the format for this discussion was based off of the talk I do, the PE story for FOAMfrat in our live classes. And so what we do is we paint a case scenario, and then we have certain like decision points where we stop and then we talk about it. So let's roll right into the episode. If you guys are interested in learning more about our live classes, go ahead, check out foamfrat.com. You can click on the blog podcast, and we have links to all of our classes. If you go to like the main landing page as well, and then we send out weekly updates with those classes that we're going to be teaching for that week. All right, man, let's roll it. We'll start off. You're going to a facility for a patient that has a pulmonary embolism. You walk in, they're intubated, they're on Levofed, I don't know, like 5-10 mics a minute maybe. They're on heparin, and they tell you that this patient came in with respiratory distress. They had an elevated D-dimer, blah, 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 you name it, elevated trope, RV dysfunction. What are some of the things you're thinking when you approach a patient that's, this is the definition of a crashing pulmonary embolism? Before flight, what are you doing? Is there anything that you guys are getting ready? You putting the Lucas on? Are you adding on another pressor? What does that look like for you? We'll start off with you, Brian.
I think the first question you want to really find out is what was their last oral intake before we go in there. But in all honesty, I think these patients are interesting because this is a subset of patients that, you have to really question, number one, what they need and what's the goal. And I think for these patients is what they need is whether it's interventional radiology or a CT surgeon that's going to place them on ECMO. And I think obviously the goal is really to get them there. And I think with that being said, you really want to optimize everything. And your goal with optimization is really perfusion. And I think when you think about a massive pulmonary embolism, there's kind of like we go in a couple of different directions, but in actuality, it's really just a form of cardiogenic shock. And I think the most important thing is that we really support the right ventricle. So from that aspect, I think when we're talking about supporting the right ventricle, epi is going to be incredibly helpful in these patients.
Awesome. Shane, what about you?
Yeah, I agree. I'd probably walk in the room and give, just based off the presentation, a small bolus of epinephrine, because the bradycardia makes me incredibly worried that this patient is like about to arrest in the next minute or so in front of us, because these patients are usually tachycardic until they're about to die. So I'd probably walk in and give a bump of epinephrine while we're trying to figure out kind of what's going on. But definitely getting the Lucas ready for the transport. And you said they
When you
didn't
say
get
bump too, what is a bump? Is that like your 10 mic like push dose or?
Yeah, probably a 10 mic push dose while my partner's setting up an epinephrine infusion, because I agree with Brian that they need some epi. We don't carry vasopressin here, so I probably start asking for some vasopressin too, in case that takes a few minutes for us to score. But they're definitely getting epinephrine pretty early on.
Cool. I in my talk I came up with this acronym Delta. You're not going to find this anywhere. This is just something I made up, but it's the things I start thinking about when you got like a patient that you're transporting really anytime. But I tend to really do like a checkpoint where I stop and go, all right, the D stands for destination capabilities. So like the place I'm going to, can they put them on ECMO if they need to? Like what are they going to do differently at this facility, if it's interventional radiology, blah, blah, blah. And then like the expectations, I think, are very important to lay out. Like, hey, I expect that this patient's going to go into cardiac arrest. Like, let's get the Lucas on. Let's prepare for this and be very clear with it. So that way, when it happens, it's just something that we were foreseeing that was going to happen. And then the L is the Lucas. It's very niche to like where I work, but getting the Lucas on, back plate, getting everything set. And then the T is tempo. I try not to let situations change the tempo of how I work, but it does, right? I mean, we know it does. And you're going to have a patient that's got a thoracic aneurysm or a STEMI, and that tempo is faster because you just got to get them to that other place, right? As opposed to you pick up a sick septic patient who's going to this hospital because they have CRRT or whatever. That's a little bit different pace of tempo. And then the A is advanced directives. And so that's what we did. We were like, all right, we expect that we're probably going to be doing CPR before the end of this flight. Let's get the Lucas on and let's start trying to get that blood pressure up and the heart rate, right? Because that's a bad sign. When you have a patient that has a low blood pressure and they're bradycardic, they're really giving you all the signs and symptoms of like an inferior wall MI. And that's because it's affecting that right ventricle. And so just a quick little definition thing. So the difference between a massive and a submassive PE is a submassive, you have a blood pressure greater than 90 systolic, but you got signs of like RV dysfunction. You got an elevated trope, elevated BMP. Once your blood pressure drops below 90, you're on a pressor, then that moves to that massive. And it probably has a little bit to do with the clot burden, how big the clot is, but also the secondary like cytokine release and inflammatory mediators that actually start to leak free fluid into the interstitial space and then around the vessels. Because you think about inflammatory mediators typically like vasodilating, like in sepsis or whatever, but it allows this free fluid to get into the interstitial space around the vessels in the pulmonary vasculature and actually causes a tightening. So we get the Lucas out. We're getting that all set up. We're going to get another pressor on. We go up a little bit on the levo. I think we went from 5 to 10 mics a minute. And then we're trying to figure out what's the best goal here, or not goal, but what's the best drug for blood pressure in a PE. And so that's the next decision point I want to bring us to is blood pressure. So IV fluids in this situation, not a good idea, right? Unless they're just floridly like they've lost a ton of fluid somehow. If you look at the IVC on these patients, it's typically plethoric, it's big, and flooding them with more fluid is just going to cause more IV dilation. Are we all in agreement with that?
Oh yeah, absolutely.
So are you Shane, I know you have ultrasound work. Are you throwing it on and looking at the IVC just to try to get an idea of how bad that RV strain is right away? So IVC and then looking at the RV?
Yeah, I'd probably use it as a guide because, like you said, they're great majority of the time going to be plethoric unless there's something else weird going on.
Yeah.
But I think it's super quick to get the view and then move up to the heart rate after.
Cool. All right. So then the next question is, are we turning up the Levofed, or do you want to go from 5 to 10 mics or 12 mic or whatever, or do you want to add on epi at this point?
I think since the fact that they're bradycardic is I would go with epi, and epi has a whole bunch of other benefits, especially in the setting of this RV failure from a pulmonary embolism. You get the positive chronotropic effects. And I think that the bigger thing is they're bradycardic, right? And in these patients, like that's the final pathway before they code. So I think that's really going to be your pressor of choice, especially in the critical care transport setting, is starting epi and really try to maintain a map of ideally greater than 65 to really ensure you have that good right coronary artery perfusion and supporting that right ventricle.
What are you starting your epi at, Shane?
I like, especially since they're already on Leofed, I probably, if I'm going for the inotropic effect, probably start like 2 to 5-ish, but I wouldn't be too fearful of turning it up, especially since you said this patient was had a garbage blood pressure, and we already gave the 10 mics of epinephrine, so that should give us a good gauge of at least where to start roughly. So if I had a pretty significant overshoot of the blood pressure, and the next one pops up 160 over 100 or something, I would certainly not go up to 10, but it would kind of, I'd use that as like an epinephrine trial to see how well they did with that first bump.
Awesome. Yeah, I think it's important to stress, like, you're not giving the epi for the left ventricle, right? I mean, you are in a way, but you're giving it for the right ventricle, because when you look at a ultrasound, you look at a peristernal short view, you see the ventricle looks like it's just asking, the left ventricle looks like it's asking for preload, right? It's very underfilled, and then you have a very overfilled right ventricle. And so you're trying to give the power to the right ventricle to muscle through that and then kick that blood over to the left ventricle, so that way you have enough preload there. So that's why epi makes sense here, because you're trying to strengthen that right ventricle. Now, when it comes to heart rate, do you think that increasing the heart rate is going to, well, I mean, obviously it's going to increase your myocardial oxygen demand, right? Do you think that works against us, or it helps in this situation?
I think in this situation, they're bradycardic, so you want to improve that. And I think if you see a bradycardic PE patient, that's something that should be very, very concerning. And I think you really need to support that heart rate as well, just to bump it up. Because again, the whole goal here is to get them to where they need to be in terms of destination therapy, whether they're being placed on ECMO, whether they're getting a median sternotomy to have that clot pulled out, or they're going for interventional radiology. I think that's really the goal. And if the patient's profoundly bradycardic, profoundly hypotensive, the end game is probably going to be an arrest. So I think,
and Brian, you do that
heart rate.
You do that pulmonary artery assassin talk for the for FOAMfrat in the live classes. You go over the RV spiral of death in that.
Yeah, and that's, I think if you really look at the RV spiral of death, and what's interesting about the RV spiral of death, it's in RV failure as well. And I think from a paramedic standpoint, the RV for a long time is something that really didn't get talked much about. You would learn in paramedic school that it's a form of, the most common cause is LV failure, but you don't get a whole lot of information on that as a topic. And I think when you look at that RV spiral of death, it's interesting because there's so many different points that you can enter that. And then it's, when you're looking at it, it's very difficult to get out of. And a lot of the treatment that we may do is really going to impact that spiral. If you give more fluids, so on and so forth, that becomes very problematic.
Yeah, when you look at it, so just if you guys are wondering, what's the RV spiral of death? So imagine right ventricle trying to pump against a clot burden inside the pulmonary artery. And so you're going to start backing up, you're going to get some resistance. As that RV starts to dilate, it starts to push on the walls of that right ventricle and blanch off the coronary perfusion. And so when you do that, and that RV is not used to a lot of pressure there, it's used to being perfused during systole and diastole, the coronary arteries, it starts to cause like an RV infarction, because you have so much volume sitting inside that right ventricle, just pushing on the walls and increasing coronary artery resistance. And so that further compromises your RV function, which makes it get even bigger. And so that's what, when we talk about that RV spiral, it's, all right, big RV pushing on coronary vessels, causing RV infarction, and then causing further compromise in that ejection fraction. What's cool is the RV is pretty good at bouncing back. Like you do that to the LV, you're probably going to have a pretty permanent infarction, or pretty permanent scar tissue and consequences. The RV can bounce back pretty quick, but it really is quick to peter out and not be able to contract against that. So, all right, so we're adding on epi. And are you turning down the levo, or are you leaving the levo where it's at for now until we start getting ahead of this?
I'm leaving it for a hot second. I just don't. At least give it a couple minutes to see what happens, and then maybe kick it down. But you said you had it up to 10 at one point. You added,
yeah, we'll say it's at 10 now. Yeah,
I'll leave it for a hot second before I kick it down too much more.
All right. So we got the epi on, and we'll say you get a bump in your heart rate, and you start noticing the blood pressure coming up a little bit. Shane, you mentioned vasopressin, something I don't carry either. Is that something you'd ask to throw on in the background?
Yeah, I'd probably start. It takes a little while for it to kick on, especially in comparison to the epinephrine, but it doesn't increase the pulmonary vascular resistance as much as the epinephrine would. You might be able to titrate down or kick off the Levophed, especially if you have that running
Cool.
along with the epinephrine. So I'd probably ask for it pretty early on.
What map are you looking at before you start turning down the Levophed?
Probably 65. It's probably a little bit around 70. The 65 buffer is kind of where I want to hang out.
Yeah. No, I agree with that. I think that's exactly what I would do too. As soon as that comes up, then start coming down with one of them. All right. So the next thing is this patient. We obviously need to be thinking about fibrinolysis, right? Some sort of fibrinolytic for transport. We know the MOPET study or MOPET study stood for moderate pulmonary embolism treatment with thrombolytics. They looked at patients getting 50 milligrams over the course of 2 hours, with heparin or just getting heparin alone. They obviously found that with the fibrinolytic, that these patients had lower cases of RV dysfunction, pulmonary hypertension, recurrent embolisms, blah blah blah. So it's probably something we're going to see. I don't know whether they're doing 100 or 50 is going to depend on the physician and what study they read, but you may see either of those. Typically, it's given as a bolus, and then they run it not over an hour like we're used to seeing with a stroke, but like over 2 hours is what I've seen. Have you guys seen the same thing?
Yeah.
Yeah.
And I think it's very dependent on the patient's presentation. I've seen where they're, the patient's getting ready to arrest and they're just throwing everything at them and they're just giving them, TPA and going from there to see really what happens.
So we're starting the TPA. They give the bolus. They're starting the drip, and then the question comes up: oh, do we keep the heparin running while we are giving the TPA? And if you look at the MOPET study, you'll see that they had heparin bolus 70 units per kilo per hour. The bolus was 7 units per kilo. Then they were running it at 10 units per kilo per hour. And then they gave the TPA bolus 10 milligrams, and they kept it running during the entire infusion of the TPA. So they kept it running at 10 units per kilo per hour. Then 3 hours after the TPA finished, they bumped it up to 18 units per kilo per hour. So my question was, well, do you keep these both running? Like, obviously you want them both in different IVs, right? We don't want them in the same line. But do you keep those running together, or are you going to stop the heparin, let the TPA go in, turn off the TPA, and then start the heparin back again? Brian, you want to take that one first?
Yeah, I think from what my experience has been, it's very dependent on sort of the receiving physician. I've seen both where they're still receiving heparin with TPA, but I think more and more, I think it's probably more common for you to see the heparin stopped in that case. And I think the big theory is that there's an increase, you're just increasing your risk of bleeding with doing both of them at the same time. But that being said, I have seen them, I've seen both. And I think it's sort of dependent on, the institution you're going to, as well as, the receiving physician of what they're going to, what their sort of goal is for this patient. But I wouldn't be surprised if you saw one or the other.
Shane, what do you think about that?
I usually see them both going at the same time. And it seems like it's a conversation more often than not with the receiving physician, like Brian said, and they'll say, just keep them both running, especially for somebody that is that acutely ill. Just be careful you don't drop them or something.
Yeah, no blood sugar checks on them. All right, so keep them. Well, I guess we'll conclude by saying that you should just look at what your local guideline says to do. If it's not in there, then ask the physician what they want you to do. If they want to keep it going, because you'd hate to show up and what? You turned off the heparin? Why would you do that? Because when you think about it, heparin is to prevent that clot from getting bigger, right? The heparin's not really breaking it up; it's just preventing it from getting bigger. And then your TPA is actually converting that fibrinogen to fibrin and breaking down that clot. So they're doing two different things. It's not like they're both doing the same thing. So theoretically, it makes sense to keep them both going, but definitely ask to make sure And, if you don't know, then call the receiving facility and see what they recommend, because typically they're going to have a little bit more knowledge of that than the referring, or at least what they want and their goals. All right, so let's move on to ventilator setting. So this patient is on the ventilator. She's already been intubated, or he's already been intubated. Obviously, if you don't have to intubate, you want to avoid that, right? Typically, a lot of bad stuff happens when you intubate a crashing acute pulmonary embolism patient. But we're already past that point. They're already on the ventilator, and the provider says if you go up to anything above 0 of PEEP, you're going to notice the patient's blood pressure crashes. And so they said, we're keeping that PEEP down to nothing, and the tidal volumes are really low as well. Is there any merit to that? Have you guys seen the same thing, where if you go up on the PEEP at all, you start seeing the hemodynamics start to crash?
I think the RV is just so sensitive in this case that, any substantial increase. I usually haven't seen too many issues like where I've had to keep it at 0. Usually around 5, they've been fine. But I've certainly seen if you go past that, or like a reflex for any hypoxia, then they end up getting way more hypotensive.
Yeah, I wouldn't be super concerned with 5 of PEEP, but I think the bigger thing is what kills these patients is intubation. And I think that's something you want to avoid at all costs. And obviously there's instances where your hands are tied and like they need to be intubated, but I think that's what's really going to drive the mortality in a lot of these patients is, failure to optimize them should you need to intubate them. And that becomes very difficult. I think the 5 of PEEP is if the patient's having a response to it, obviously don't mess with it. But I would say that the intubation is far worse. And if they're on 5 of PEEP or no PEEP, it's kind of irrelevant.
Yeah, it's interesting when you look at like the pulmonary vascular resistance and different tidal volumes and different like lung volumes, you notice that the least amount of resistance going through the pulmonary vasculature is when you are at functional residual capacity. So you're like oxygenated, so you don't have any hypoxic vasoconstriction, but you also are not delivering a big, large breath, right? So that's where you have the best flow moving through there. And so if you're hypoxic or you're not oxygenating adequately, you have somebody that's got a big chest wall and they're getting atelectasis, that is going to hurt you more than giving them some PEEP to keep that open, because you have to remember that functional residual capacity is relative to whatever condition they're at, right? That's just where the chest comes to equilibrium. So if you're relaxing the chest wall, if you got them laying flat and supine, they're going to be closer to that residual volume, and you may not be oxygenating the best. So what we did is we said, all right, we turned the PEEP down to 0, and that seemed to be the magic number for this patient. Now, I have noticed a spectrum where the sicker the patient is, the lower you have to get on that PEEP. So you may be fine with 5 or so, 3, 5 in some patients, but others you probably have to go really, really low. And you can do little trials. Now, this particular patient was very small body structure, very low BMI, but I have a feeling if they had a larger BMI, if they were a larger patient, then I would be battling atelectasis with trying to just keep a little bit of PEEP on to combat that transalveolar pressure with whatever that pleural pressure was. I think it makes sense. There's that Dan Davis model of like the hypotensive ventilator strategy where you use like a little bit larger tidal volumes, and then you have more space between the breaths, so you're not giving as many ventilations, because with every ventilation comes a certain degree of dead space, right? So his idea was that you increase alveolar ventilation, and maybe you have a little bit larger of a tidal volume, but then you have more time in between those to let that flow through the pulmonary vasculature take place. Anything you guys want to add to that at all?
I think with all of this, the main thing that's important is that all these patients present differently, no matter what their pulmonary embolism is. And as you said it before, it's not really the PE, it's the physiologic response. Because you can have a patient that has a saddle PE or a left main PE that presents fairly stable versus a patient that has a segmental PE that's in or cardiogenic shock. And I think that's really the thing. So you really have, from a approach to these patients, you really don't know how they're going to present, and what their response is going to be to really anything. So it's very individualized in terms of their management.
Yeah. Shane, anything to add to that?
No, I agree with Brian that it's going to be a little bit of trial and error for a couple minutes there, trying to figure out where to dial them in to balance the oxygenation and the fact that they're going to get hypotensive if you go too hot on that PEEP. So I agree. It's going to be a few minutes of trying to figure out that sweet middle ground for them.
Cool. All right. So you got epi on, blood pressure came up a little bit, not a ton. Heart rate came up a little bit more. You got them switched over to your ventilator. You got the Lucas on, you got TPA running, and you're like, still, this patient does not look like they're going to make it through the flight. Is there anything else you're doing before you leave?
Talking to the family about expectations.
Yeah, no, I mean, I think that's really good. So my question here, and this is a little abstract, but I was listening to a talk by Oren Friedman, who was at the MCRIT conference. He's got a pulmonary embolism response team, like a PERT team, I guess is what they call it. And what I thought was interesting is he said, when you like are removing somebody's lung or removing a lung because of lung cancer or whatever, or doing a lobectomy, and you clamp off a branch of that lung, like the pulmonary artery branch to that lung, you don't see this like massive RV dysfunction that occurs like you do with a pulmonary embolism. And I was like, that's really interesting that you don't get that same response. And he said it's because the other lung will dilate out its vasculature to receive a lot of that blood and to get it over to the left side. So he said a lot of the RV dysfunction you see, while there's a majority of it that is from the clot burden, is from inflammatory mediators and the cytokine storm that occurs. And so his argument was for pulmonary vasodilators. Stuff like your epoprostenol or INO. And I was reading a blog post by Josh Farkas called like the pulmonary vasodilator under our nose the entire time, and he was talking about inhaled nitroglycerin and utilizing that to try to open up some of that vasculature and cause a little bit of a reduction in the RV pressures. Is that something you guys have heard of or have ever done?
I've heard of it, and I think this is where you want to be, have a conversation, hopefully with your medical director way ahead of this calling, because I could see, somebody calling and saying, "Hey, should we try nitroglycerin?" Then your medical director saying, "Well, what the hell is going on?" But I think that's important, especially with these inhaled vasodilators to really help with that RV failure. Because I think when you look at pulmonary embolisms, a lot of it's about that inflammatory cytokine release that's occurring within the lungs. But I think it's definitely an option. You've seen places put them on EPO fairly quickly to help with that RV failure as well.
Shane, have you ever transported anyone on a pulmonary vasodilator for PE?
I have not, and we don't do the like inhaled nitroglycerin at this point, at least. I've seen and read a few articles on it. I know I think Brian talks about it in his class a little bit, but I have not transported anybody with them.
Yeah. I don't know if the evidence is there yet, if it's completely panned out to show a benefit. It makes theoretical sense that it would help decrease the RV pressure, but it was just a decision point I threw in here because I was like, well, is there anything else that we can do throughout this transport? So the main takeaways I got from this are, the first thing is knowing that when somebody says this is a massive PE, that's actually like a definition. Like it's not just them being like, oh, this is a gnarly PE. It's like there's actually a definition, which is that they have a systolic less than 90 and they're on a pressor. When it comes to the pressor, epi seems to be the one that's like the main one that people say to use for your first line. However, I have read a bunch of literature saying Levophed is also really good too. So it probably just depends on what you're reading, but I have a feeling the sicker the patient gets, the more likely epi is going to be the one that you want to use. Then when it comes to the fibrinolytics, definitely start that conversation, get that going. And if you see them use 50, Evidence shows that 50 is probably just as good as 100 with lower risk. So that seems to be the number. Is that what you guys are seeing too?
Yeah, even especially during like if they end up going into cardiac arrest pretty early on, it seems like people are giving the 50 bolus pretty quick.
Yeah. And then if you're not sure if you should run that with the heparin or not, just ask and see if they have a recommendation for it. Ventilator settings, probably lower peeps, probably around that 0 to 5 range, and it's going to depend on the patient, their body habitus. The main thing is at their FRC, you want to keep it well oxygenated. You don't want atelectasis because that's just going to increase the pulmonary vascular resistance anymore. All right. Anything else we're forgetting, guys?
Just one thing: if the patient goes into arrest and they have not gotten thrombolytics, I was reading last night, like some of these places will recommend doing over an hour of CPR once they commit to giving the thrombolysis.
Oh, wow.
Once you push it and you say like, maybe we should give this a crack, you're usually stuck doing CPR and waiting for that to actually circulate and hopefully break apart a little bit of the clot enough to some circulation. So you're committed once somebody suggests pushing it, you're doing CPR for a while.
I wonder too, like sometimes like if doing CPR like breaks that clot up, because you feel like you're pushing like right in that area. I'm like, man, I wonder if this is breaking it up a little bit.
I'm not that strong.
Awesome. Well, guys, thank you very much for letting me pick your brains on this. And if you guys have any questions, email us team@FOAMfrat.com. We'd love to hear of any crashing cases that you have. And actually, it'd be cool to have you on the podcast and run these by us and everybody pick each other's brains. We don't have all the answers, but it's fun to get our heads together and to think through these cases. So we'll see you guys next time. Thanks for hopping on.